I'm Paul Sugarbaker, and I'm the editor of the textbook and video atlas of cytoreductive surgery and perioperative chemotherapy. Here with me today is David Morris from Sydney, Australia. David is one of the senior contributing authors to the textbook. David and I have just finished watching the video entitled Proactive Second Look Surgery for Transverse Colon Cancer at High Risk for Progression. David, do you think that there are groups of colon cancer patients who require second look surgery and HIPEC as part of their standard of care?
Paul, yes I do, and thanks for having me here today, and thanks for involving
Pleasure.
me in this. I think that peritoneal cancer treatment in colon cancer has altered so much, and I think that this patient, this case, is really one of the most important current areas. Clearly there are patients that we can identify that are at very high risk of development of peritoneal carcinomatosis. And perhaps we should go through those.
Let's do it, yes.
In detail.
Okay.
So I think that if you have Krukenberg type tumours of the ovary,
okay,
I think that almost all, perhaps all of those patients will develop peritoneal spread of their cancer.
Now, don't let me interrupt you, but this is even if the surgeon performing the primary colon resection removes both those ovaries and tells you he doesn't see any further evidence of peritoneal seeding?
Correct.
Okay.
So I do not believe that that is, well, I know that that is not an adequate treatment.
That can't be a curative approach to this situation,
No.
okay?
Another group of patients that I think are in exactly the same group are patients who have cancer on the surface of the resected specimen,
okay,
that had peritoneal disease, but it's been removed. But we know that all of those patients, or again, almost all of those patients, will fail in their peritoneum within a short time. There are then some other groups of patients that are at considerable risk of relapse, including patients with T3 and T4 primary tumours, and patients who have had a perforation of their primary tumour. Now the percentages in those groups vary a little bit in different papers. I think some of the best data here comes from Dominic Elias, but certainly in patients with a perforation, at least 30% of those patients will get peritoneal disease. Patients with a T4 tumour, more than half of them will get peritoneal disease at a year at a second look operation.
Now, do you think that there are different categories of risk in this group of patients? Do you think that the risk of those patients who have demonstrated peritoneal seeding at the time of their primary colon cancer resection, are they somewhat different than those patients who have, say, a T3 or T4 lesion or have perforation? And do you think that the indications for a reoperative approach might be different in these different groups?
Yes, I believe that the patients with ovarian secondaries and surface secondaries on the resected specimen have peritoneal disease and should be offered surgery. I think that the patients who are at high risk of developing peritoneal disease in the other categories we've talked about should be cancelled about peritoneal disease. The real problem here, Paul, is that peritoneal disease in colon cancer, when it's diagnosed, has such a poor prognosis that I think that the possibility of preventing that situation should be thought about very carefully. And I certainly would cancel patients with T3, T4 and perforated tumours about their risk of recurrence. And I think that in many of those patients it would be appropriate to give them HIPEC straight off. I think that in others who are more doubtful about having it, at least a laparoscopy to see if there is any disease there at that time would be sensible.
If you're performing a resection for a primary colon or rectal cancer and you find that the patient has peritoneal seeding, would you do the primary colon resection and then proceed to peritoneectomy and HIPEC at that same procedure?
Yes, I would.
You would?
And I think that that's the very best time for us to treat these patients. They don't have the adhesions from previous surgery. And the other thing is that most patients would rather have one operation than two.
Definitely.
So yes, I believe that we should be involved whenever possible, as early as possible in their patient's disease.
Some have suggested that a second look in this group of patients is too invasive, and that we should think about a second look laparoscopy rather than a full surgical intervention. What do you think about using laparoscopy for the selection of patients for second look?
If a laparoscopy is positive and tells us that the patient has peritoneal disease, then I think that's useful. If the laparoscopy is negative, I think the really tragic thing here is if we miss people with peritoneal disease with a laparoscopy that could otherwise be cured. And if we miss those patients with a laparoscopy, as I believe I would, I do not believe that I can look at every nook and cranny of the peritoneum with a laparoscope as well as I can at open surgery, then I'd be concerned that we would be under-treating patients.
In this particular video, we found a 2-centimeter deposit of cancer way down in the trites ligament area. I personally don't know how even the most experienced laparoscopic surgeon would have found that particular nodule, which in all honesty, had we not specifically looked at the ligament of trites as an area at high risk for peritoneal metastases, we wouldn't have made the diagnosis of disease at that site. And I agree with you. I don't think that laparoscopy can ever really rule out the presence of peritoneal metastases. An important consideration is response to chemotherapy or a failure to respond. And certainly those patients who fail to respond to chemotherapy prior to their second look can actually be damaged or suffer from a delay in definitive treatment. What are your thoughts about the interval between the diagnosis of peritoneal metastases at the time of primary resection and the subsequent second look? How long should we wait?
I don't know, Paul. But like you, I worry a lot about people progressing whilst on the chemotherapy.
Yes, okay.
And we know both from French data and from Dutch data that patients in that situation that are progressing on systemic chemotherapy, if they are then subjected to peritonectomy, have good outcomes. So I don't think we can say that these are biologically bad patients and are not possible to salvage. So I think it's very important if we're going to use neoadjuvant chemotherapy that we watch for progression and operate on people that do progress. The optimal length of chemotherapy prior to a peritonectomy procedure is clearly unestablished. I don't think we know what is an adequate length of time, or even if preoperative chemotherapy really adds anything to doing the procedure and giving the chemotherapy afterwards.
I take it that you don't think that a failure to respond means second look is not indicated?
Correct.
Correct. Okay. David, in this patient, we used an open a technique for HIPEC, and I know there's a number of different ways in which one can use the perioperative chemotherapy. Can you give us your ideas regarding the use of open versus closed, oxaliplatinum versus mitomycin C? What is it that you're doing at this point in time?
Okay, so we do semi-open, so we suspend the abdomen from a frame, like you do.
Okay.
And then we have a membrane over the top of that to lessen the risk of exposure to our operating theatre personnel. I'd have to say that I don't believe that any harm has come to operating theatre personnel from perioperative chemotherapy that I'm aware of, by whichever technique. The supposed advantages of the closed technique, where you close the abdominal wall and give the chemo, I think are theoretical, so we don't have any evidence of harm with an open technique. We certainly have evidence of better distribution of drug with an open technique. And at present, we have no evidence of difference in outcome between open and closed. But I think that we currently don't have adequate studies to look at that. So I use open technique. What chemotherapy do I use? I, like you, used mitomycin. We did change in our colon cancer patients to oxaliplatin, essentially because we can then avoid the post-operative EPIC, which lessens their hospital stay. And we do have data showing that our hospital stay is considerably reduced if we avoid EPIC.
I think that is true, yes. I think that this patient demonstrates a new direction in which we're taking cytoreductive surgery and HIPEC in patients with colon cancer. Where do you think we're going with this approach?
Paul, let's have a little bit of history.
Okay.
It's so exciting that in patients like this, we can offer them at least a 50% chance of long-term survival, probably better.
And you say that because the PCIs should be in the
very low
10 or less range.
Yeah.
Yeah, okay.
And that is such a change. Now, it's true that there is lots more progress we need to make in treating patients with peritoneal spread of colon cancer. But clearly in these patients with early disease, the results are very, very good.
On that optimistic note, we'll call this interview to a close.
Thank you.